Hello, everybody, and welcome to another one of the Institute of Osteopathy's webinars. Today we're delighted to have Alex Corser and Zoë Clark, who are going to be talking about axial spondyloarthritis and Ehlers-Danlos syndromes. We're just waiting for a few more delegates to join in. We've just hit the 2 o'clock mark. We'll just wait for a moment or two. The process of the webinar today, Zoë and Alex will go through the main presentation of the webinar. By all means, do forward your questions through the questions button, and we will take a Q&A session towards the end. Probably leave about 10-15 minutes for questions, hopefully. If you can do most of your questions through the questions portal rather than chat, it just makes it a little easier for us to manage all the questions coming in. Do let us know if you have any pointing out that there's an echo. Hopefully that should improve now. Okay, thank you guys. Yeah, might be because we've got all the speakers on. We've got the echo. So I might ask the panelists to mute themselves if they're not speaking. That way it stops a little bit of the echo. Okay, great. So I think we're nearly there. So I think I'm going to hand over to Alex and Zoë, who will introduce themselves, and we'll get going on the webinar.
So hi everybody, welcome to today's webinar. My name's Alex and you can hopefully see Zoë. Zoë, do you want to say hi?
Hi everyone, thanks for joining.
So just a little bit about us. We work together with another person called Andrew McMillan, and we were teamed up to create a company called Educate and Advocate Training, and we're providing postgraduate level training, looking particularly at training practitioners to recognise conditions that have a significant delay to diagnosis at the moment. So a little bit about me. I am a practice principal at the Penn Clinic. I kind of deal with the complex cases and paediatrics. I've been teaching within the osteopathic circuit for about 7 years, with a high sort of interest level in research and working in an evidence-informed way. And as of hopefully next month, I will have finished my PG cert to be considered a specialist paediatric osteopathic practitioner as well. And then Zoë can tell you a little bit about her.
Thanks, Alex. Yeah, so my name is Zoë Clark. I'm an osteopath and I practice in East Anglia. I've been working both with Educate and Advocate Training and through the Institute of Osteopathy and National Axial Spondyloarthritis Society to educate osteopaths and chiropractors all about axial spondyloarthritis, but I also have some special interest in Ehlers-Danlos syndromes and hypermobility spectrum disorder too. Since 2017 with NAS, the IO and the RCC, we've worked on a publication about osteopath and chiropractor knowledge of axial SPA, and also created a referral template letter that we'll be going through in this presentation. I've also been interviewed on Channel 5 News and spoken in UK Parliament about my own experiences of delayed diagnosis of AS as well. And I'm currently working with NAS on some self-management resources for people living with axial SPA to help with the rheumatology clinics being delayed at the moment as well.
So initially what we're going to go through, Zoe's going to take you through AXPAR, and then I will take you through very much a whistle-stop tour on Ehlers-Danlos syndromes, because there is way too much to cover both of those conditions in 45 minutes with some time for questions. But if anything comes up, as Katie said, please just ask us and then we'll spend some time doing that at the end, all right? So Zoë, over to you.
Yeah, absolutely. Both these topics in and of themselves are massive topics. So today we're going to focus mainly on the screening and referral process, but do feel free to ask any questions. So I'll be going through axial spondyloarthritis. So firstly, just to get the terminology right, axial spondyloarthritis is an umbrella term that's relatively new, and it includes ankylosing spondylitis. So ankylosing spondylitis is when you have radiographic changes visible on the sacroiliac joints or the spine, and that's also known as radiographic axial spondyloarthritis. Non-radiographic axial spondyloarthritis is when X-ray changes are not present, but on an MRI inflammation is visible or the patient has the symptoms present. These are diagnosed by consultant rheumatologists, but certainly I think osteopaths need to be really confident in recognising these conditions and referring on when we do spot them. So the prevalence of AS to the non-radiographic axial SPA is 1 to 1. So in the UK, there's a significant population of people affected by this condition, with around 220,000 adults living with it. That's 1 in 200 people, and that is the same if you combine the number of people affected by MS and Parkinson's, it comes out as the same. So it's surprisingly common, but actually part of the reason we don't really recognise it, I think, is the change in terminology and also a few myths as well that tend to carry on. At the moment, the average age of onset is 24 years of age, but symptoms do tend to start in the late teens to early 20s. And currently in the UK, there's an 8.5-year average delay to diagnosis. And in that time, patients can have considerable changes and irreversible changes with the radiographic symptoms. They also can experience a higher disease burden, and a longer delay to diagnosis is associated with reduced response to the medications that can be prescribed for this condition. So it is really important that we do pick up these patients as early as possible and get them the right diagnosis so they can get the right treatment. Interestingly, one of the myths that does really carry on even now is that more men are affected by axial SPA than women. In fact, it is a 1-to-1 prevalence between men and women. Men do tend to have more of the radiographic changes and be diagnosed with ankylosing spondylitis, whereas women tend to have the non-radiographic axial spondyloarthritis. But interestingly, women do have a higher disease burden than men on average, studies have found. So I'll go through the symptoms of axial SPA and then I'll go through some questions that you can use in clinic to help screen for this. So the major symptom is inflammatory back pain, which I'll go through on the next slide, but you also need to be asking about the extra-articular manifestations. So the extra-articular manifestations are the other symptoms that can go alongside with axial SPA, and they can be a really easy way to screen these patients and pick them up quite early on in clinic. So commonly patients can have enthesitis, most commonly in the Achilles tendon, acute anterior uveitis or iritis, which is a very painful inflammation of the eye, which causes a lot of photophobia, and it is a preventable cause of blindness as well. So it's something that needs to be treated urgently in A&E. Dactylitis, which is inflammation of a digit, either on a hand or on a foot, and psoriasis, as well as inflammatory bowel disease, so both ulcerative colitis and Crohn's, and fatigue as well. So in terms of the inflammatory back pain symptoms and the other questions that we want to ask in clinic, I'll go through the different sections that you can do as a really good way to screen, and we do also have a screening questionnaire that we can always pass on to attendees afterwards if that would be helpful. So firstly, you want to ask about the onset of the back pain that patients are experiencing. So generally with inflammatory back pain, it will start before 45 years of age, and it will generally be a gradual onset rather than sudden, and usually the symptoms are lasting longer than 3 months. It is very important to ask when the back pain symptoms originally started, because if you're seeing someone who's over 45 years of age, it may be that they've been having episodes of back pain from the early 20s or from many years before. So you can't necessarily rule out inflammatory back pain just because the current episode is after 45 years of age. So it's worth asking that. Then you also want to look about whether the symptoms are an inflammatory pattern. So with back pain, with inflammation, the daily pattern tends to be that symptoms are worse in the morning and then gets easier through the rest of the day. They also, in terms of aggravating and relieving factors, a good way to distinguish between mechanical back pain is that with inflammatory back pain, it tends to be better with movement and isn't improved by rest. So that tends to be the other way around with mechanical back pain. And also patients often experience night pain, so the pain will be waking them, especially during the second half of the night. And of course, if patients are getting night pain, we would be screening for red flag symptoms and possible pathology anyway. And then also you want to look at whether anything helps in terms of anti-inflammatory medications, because inflammatory pain does tend to be improved with the non-steroidal anti-inflammatory drugs. Although, of course, with axial SPA, it's important to recognise that some patients don't find much help with ibuprofen. So this question can be helpful in conjunction with other things, but it's not necessarily helpful on its own. And also importantly, specifically for axial SPA, inflammatory pain, you want to ask about any alternating buttock pain, particularly over the SI joint area. So often when patients describe back pain or hip pain, they may actually be pointing to the SI joint. SI joint pain is very closely linked with axial SPA, so if someone's presenting with these symptoms, we need to screen them really, really thoroughly for the symptoms of axial SPA and refer them on if something comes up. Also looking at the history, you'd ask both about the personal history and family history. So you'd ask about any family history, particularly first degree relatives of axial SPA in itself, of reactive arthritis, psoriasis and inflammatory bowel disease as well. And then also acute anterior uveitis too. And then we can screen for the extra-articular manifestations that I mentioned in the previous slide. So one of the important things, if someone's already had acute anterior uveitis, then generally they'll definitely remember it because it is very painful and because the treatment tends to be quite a number of weeks with steroid drops in the eyes, or depending on the severity, sometimes steroid injections directly into the eyes. So generally, if someone's had these symptoms, then they will know about it and they'll remember. But with a lot of these symptoms, if someone's coming in to see you because they have back pain, some of the symptoms that you're asking about, including GI symptoms, people may find it difficult to understand why you'd be asking these. So generally, before I ask the questions about extra-articular manifestations, I'll just set things up by saying that I'm just asking about symptoms that could be a sign for inflammation generally in the body. And then that gives me the information to make sure that I'm giving them the right advice. Generally, once you've set things up in that way, people are a lot happier to answer these sometimes seemingly random questions. So the other extra-articular manifestations you want to ask about are fatigue. So with this in particular, patients really commonly rationalize their symptoms. So they may well put fatigue down to their lifestyle, down to their mattress and things like that. So you really need to be confident in asking questions and really drilling down on the possible cause of the fatigue. So sometimes you can ask patients whether their fatigue is worse than someone else of a similar age or worse than someone else in similar circumstances, like other people with children at the same age, and you can just see whether this fatigue may be unusually high compared to other people. Dactylitis is a really common extra-articular manifestation, so it's important to ask about that. So again, that's swelling of a digit in the finger or a toe. With this as well, you want to make sure that you're asking patients to think back in their entire history. So they're not just thinking about current symptoms, they're going to be thinking about past symptoms as well. With psoriasis, it's very important to check with them if they have a diagnosis of eczema to make sure that that's a correct diagnosis. So ask about the location that they experience it and who diagnosed it as well. With psoriasis in particular, you can also check the hairline to see if there's any scalp psoriasis that patients may be unaware of. And then ask about any other peripheral arthritis and any other joint pains. Commonly with axial SPA, you can get random joint pains and joint swellings. They don't have to be bilateral, they can be unilateral. So it's well worth asking about these. And then in terms of enthesitis, to help screen for these, I would ask about any history of rotator cuff problems, any tennis or golfer's elbow, any plantar fasciitis or heel pain or Achilles problems, and keep it quite broad and general so that patients really think back through their whole history and they may come up with other symptoms that they wouldn't have thought were related. And then in terms of the previous investigations, we'd be particularly interested if the GP has referred them for blood tests for inflammatory markers before, and if they've had any scans of their back as well. With axial SPA, the inflammatory markers, ESR and CRP, that we tend to assume mean inflammation, tend to only be raised in around 50% of people with axial SPA. So they can be helpful in conjunction with everything, but an absence of these markers does not necessarily rule out axial SPA. Even someone who's in an active flare-up of AS can still have no inflammatory markers present. A useful blood test as well is to check for the HLA-B27 gene. This is very closely linked, but there are around over 100 genes at the moment that have been found to be linked with these conditions. But with the HLA-B27 gene in particular, around 90% of people with axial SPA do have this gene. But of course, that means that around 10% may well not have this gene, but still have the condition. Similarly, around 1 in 15 people don't with the gene only go on to have axial SPA. So even if someone does have the gene, it's not a guarantee that they're ever going to get this condition. So again, it's not particularly straightforward, but it can be really helpful in conjunction with other signs, symptoms and tests as well. In terms of scans, the first port of call would be a lumbar and pelvis x-ray, because if there are radiographic changes there, then that would lead to a diagnosis of AS. But if this became back normal, then we would tend to look at an MRI of the whole spine and the pelvis, and in particular a STIR MRI, which is sensitive enough to show any inflammation. So importantly as well, we need to recognise that inflammatory changes from axial SPA can occur anywhere along the spine, so they can be in the neck or the thoracic without any changes in the lumbars or the sacrum as well. So that's why they do the full spine MRI. And next slide, please, Alex. So when we've asked patients all these questions, and I understand that it seems like a lot of questions, but as you get more practice with it, it does become a lot easier. It can be difficult to really make a clinical judgment and decide whether we need to refer someone on for investigations. So the SPADE tool can be really helpful. So this is available for free at spadetool.co.uk, and it essentially has a list of all the symptoms of axial SPA and little tick boxes that you can then tick which symptoms your patient has, click a button, and it comes out with a graph like this. There are different levels, as you can see on the graph, from additional tests necessary all the way up to a definitive diagnosis of axial SPA, but it can be really helpful to give you an idea of the level of suspicion that you have, and then give you an idea whether to refer someone on for those investigations. So if we are referring someone on for investigations, I would highly recommend using the referral template letter. This is slightly cropped. I've taken out the top part of your details and patient details, but this letter was created in conjunction between NAS, the IO, and the RCC. It's now also been validated by the Royal College of GPs and the Chartered Society of Physiotherapy, and it's available for free on the NAS Allies page, which we can link to at the end as well. So with this referral template letter, again, it's similar to the SPADE tool, so it lists the symptoms which you can tick, and then it states the NICE guidelines to give the GP a really clear idea of what you're asking them to do. So generally, if they've got three symptoms, the GP would do the HLA-B27 test. If they've got 4 or more, then they would refer straight into rheumatology. But this can be really helpful because it just gives really clear communication, and it gives you confidence when you're referring to a GP, as well as giving them clear information on why you're writing to them. Then, as I discussed, the GP may well do the blood tests. Generally, they wouldn't do the MRI. If they were highly suspecting this condition, they'd refer straight into rheumatology, because the rheumatologist is a specialist and able to distinguish between other types of inflammatory arthritis as well. Alex, do you have anything in addition to that? Oh, I can't hear you.
I think that's fine. I think one of the questions that often comes up at this point is people's confidence in actually creating that referral. And I think one of the things that is really helpful is this template. I'm really fortunate where I am that GPs respond really well to these kinds of investigations, but not all GPs are well versed in this depending on their patient population. So I think using something that is validated really opens those lines of communications and does it in a way that's respectful to the GP, but also asking for a referral to somebody who's more specialised down that road.
And also, really importantly, on the NAS Allies page, they have got a link to a consent form as well. So anyone who's using this letter, if it's appropriate, if you ask the patient for their consent to be able to send a copy of the letter to NAS directly, NAS will then at a later stage be able to catch up with the patient and see what happened through the referrals. They can track how effective the letter is and then use that to guide any future improvements as well. So I think as well, it's a really important collaboration between NAS, the IO, the RCC, RCGP and CSP as well, which I think for a condition that has such a long delayed diagnosis, I think is essential really long term for getting patients picked up a lot earlier and diagnosed.
So moving forwards, thank you Zoe for that. This is going to definitely be a whistle-stop tour. So Ehlers-Danlos syndromes are a group of disorders in the family of kind of genetic connective tissue issues, and there's lots of different variations, and they affect genes that code for collagen and fibrillin and other matrix proteins. It's very, very complicated, and they express in very different ways, but typically that would be joint hypermobility, skin elasticity, easy bruising, and atrophic scarring, and then marthenoid habitus, which is when they've got those marthenoid proportions that we talk about when we train. So that they're wider in terms of wingspan than they are in height, and they usually are long, slim type of looking people. And there are numerous, there's about 13 different subtypes. Hypermobile EDS is the most common, with about 90% of EDS being of a hypermobility type. So that's the one we're going to focus on, but I will just show you the other types. So here is an overview. When you get this as a recording, you can pause and have a look at it. But as I said, yeah, HEDS is the most common by 90%. So it has changed for everybody who hasn't been following this closely in the literature. Hypermobile EDS was considered the same as benign joint hypermobility syndrome. So it was, they still have the same symptoms. It can be very debilitating. However, it was often overlooked. And we've got to remember that it isn't just about the joints. There are elements of autonomic dysfunction, pain, anxiety. They have issues with digestion and fatigue as well. So it isn't just about how they move. So the newer classifications have described this spectrum, looking at the joint hypermobility called a joint hypermobility spectrum disorder, which we're going to briefly touch on in a few minutes, right the way through to hypermobile EDS. Classical EDS is the second most common subtype, and that's the typical features that we think about of the hyperextensibility in the skin, atrophic scarring, and impaired wound healing. And then the most serious type of EDS to be considering is vascular EDS. This was classically type 4, and it's looking at a much higher risk kind of patient where they can have blood vessel ruptures, perforation of viscera, that it can be life-threatening, life-limiting. Pregnancy is very, very difficult for any women with vascular EDS. So if ever you have anybody that reports that type, then you need to go away and do some research about how best to manage that, because they are patients who are very, very vulnerable and usually not very well. So going to our hypermobile type. So the way we define and diagnose that clinically are major and minor criteria. It gets complicated in how it's phrasing, how they look for that. So our major criteria for diagnosis are the skin involvement, so that hyperextensibility, that stretchy skin, and the generalized joint hypermobility. That would classically be looking at on a BEIGHTON score, which we're going to look at in more detail later. And then we can also consider the following minor criteria. So recurring dislocations, joint limbal pain that's chronic, so more than 3 months in duration, and a positive family history. Someone else in the family has an EDS. So if somebody has been diagnosed, then what they're looking for is one or both of the major criteria, or one of the major, but 3 or more minors as well. You can't just have minor criteria. They're not enough to establish a diagnosis. And obviously, us as osteopaths, we're not diagnosing, but we may be referring. So it's good to have a knowledge of this to be able to guide your patients in terms of what to expect, and also for your own ability to clinically reason how likely an EDS diagnosis might be for that person. So here's our BEIGHTON score. The BEIGHTON score hasn't really changed. It's been around for quite a long time. It's 9 points. So you have a look at how far the thumb can flex. So you're looking at seeing if it can come down towards the wrist. You give a mark for each side of the body, and that's how we get our 9 points, because the final one is flexing to touch your toes. So there's only one way you can do that. You're looking at extensibility of each of a finger. You're looking at each elbow, and I think the stat is if it can, if there's more than 10 degrees more than usual range of movement, and the same for each knee. And then we look and we compare that to the BRIGHTON criteria, and the BRIGHTON criteria are looking at those spectrums that we were just talking about. So that's where you get your major and your minor criteria, makes it very much more complicated. But basically how I would describe it to make it more simple in your mind is if you're getting a BEIGHTON score of 4 or more, then we need to be considering a referral for that person if they're getting any pain alongside their hypermobility. So higher than 4 and getting pain, let's think about referring this person with a supportive letter that's highlighting why we're looking at these things. So as we discussed really briefly in the intro, it isn't just about wobbly joints, and we don't have time to discuss all of the ins and outs of the neurology here, but fatigue is very, very common and can sometimes be more disabling than their pain. And then we also go into that alongside fatigue and pain, we start to get psychological symptoms. So depression and anxieties and other disorders along those lines are more common in these kinds of patients. When you start thinking about that these are lifelong conditions, so these people have had these things most of their life to date, then it isn't really a surprise that when they're suffering with pain and fatigue, that actually their mental health starts to take effect, especially because they potentially haven't been diagnosed in a timely manner, because these Ehlers-Danlos syndromes are still not well understood and often missed clinically. So we often sometimes get associated autonomic nervous system issues. So you can get problems with remaining upright, you can get blood pressure issues, and you can get problems with heart rate. And when that's quite severe, that can become something called a POTS syndrome, and that's when you can get fainting and lots of complicated symptoms with that. We commonly can get problems with digestion, so constipation, diarrhea, pain, urinary incontinence, going right through from childhood through to adults. So if you think you might be a teenager with these symptoms, that's embarrassing, it's highly difficult to cope with, and again, that's why I'm saying it's not just wobbly joints, it's affecting all of our collagen in different ways in all of the different types, and that's how it can start to affect anything that is controlled by muscle, so even the smooth muscle of the bowel, hence GIT issues. These people, if they do have to have a surgery for any reason, their skin is going to heal slower, they're more likely to get an infection, and they're more likely to bruise if they do get some sort of trauma in a different part of their life as well. So we need to be careful with these patients and mindful that they're not as robust as our other patient populations. And then we find that if this isn't being managed well, and the combination of all of these things we've just been talking about, then we start to get an effect on their quality of life. So they're not achieving at school or work, they're not doing their normal daily task, and then their quality of life can massively reduce, and that is a very difficult thing for young people to be processing. And that's where we can really, really make a difference, not only with our hands-on work and our exercise prescribing work, but actually in terms of our support and giving them an option of something that they can achieve that's reasonable and that they will feel really positive about. You can be such a positive influence for patients of this type in terms of getting them back to feeling like they have things in their life that they enjoy and are valuable to them. So moving forwards. So this is often where people get a little bit confused. So we hear about the hypermobile Ehlers-Danlos syndrome, and then we've also heard the term hypermobility spectrum disorders. So in 2017, there was a major revision to joint hypermobility as a whole, and that's often where this confusion comes from, because if you look in the literature earlier than 2017, it is called all sorts of different things, and if you look after 2017, then all of the subtypes have changed in names. So there is a reference list at the end, and a really good place to go to is the Ehlers-Danlos syndrome's website and society. They've got a list of all of the literature and all of the new names and what they used to be as well. So if you're somebody that's getting a little bit confused because everything's changed in terms of terminology, that's a great place to go and have a look just to get your clarification. So because not everybody with joint hypermobility has hypermobile Ehlers-Danlos syndrome, they decided that it was more relevant to have hypermobility spectrum disorders included, which allows us to know that some people have hypermobile joints and absolutely no symptoms whatsoever, and other people have hypermobile Ehlers-Danlos syndrome and have lots of symptoms and everything in between. Hypermobile Ehlers-Danlos syndrome is the only EDS type that we don't know what the genetic marker is at the moment. So all the other subtypes, we can genetically test the individual and we can find their subtype out. So with HEDS, we don't know that, and that's why it sometimes is still being lumped in with the hypermobility spectrum disorders. It's almost seen within the field as the most extreme version of the hypermobility spectrum disorders. Whereas the other EDS types, because they can be genetically tested for, they're moved a little bit more into their own category in that way. And having a spectrum like this, it just acknowledges that we can have severe effects on lives, but we can also have types of hypermobility that just don't fit any particular syndrome, and that's still relevant and valuable for that person as an individual to have some form of diagnosis. HSD has its own whole subtype section, which I haven't included here, but again, they can just be distal joints involved or whole spectrum. So again, it's massively variable depending on the individual in front of you. So most people that were historically diagnosed with joint hypermobility syndrome or benign joint hypermobility syndrome will have likely been moved into the HEDS category. It's really important in terms of management of these types of individuals to not create an unnecessary fear. So we need to manage them well, manage them carefully, but also give them confidence to continue to use their body in a way that is relevant and correct for them. So if you've got someone who's on a hypermobility spectrum disorder and it isn't having a massive impact on their life, then we need to talk to them in a way that isn't going to scare them about having some hypermobility in their joints. Whereas if you've got somebody coming in who's got hypermobile EDS, then we need to talk to them in a very different way, but we're trying to build that discussion in a way that is relevant to them, but also reassuring, and will give them the impetus to be able to use their body and get it as strong as it possibly can be. So the hypermobility spectrum disorders can only ever be diagnosed when all of the other conditions that involve that joint laxity have been ruled out. So EDS, Marfan's or Down syndrome have to be ruled out first. So a hypermobility spectrum disorder is a diagnosis of exclusion, and everything else must have been considered first. So here are some references for you all, and there's lots of different references here, but the one I wanted to flag to you is the Ehlers-Danlos classifications references. And what I'd like to just talk about briefly at the end of this discussion is what we're looking for clinically with Ehlers-Danlos syndromes. So if you've got somebody that's coming in undiagnosed with the hypermobile Ehlers-Danlos type, then typically you're going to get a report of increased pain. And then they may not be aware of their scarring being an issue. So there's atrophic scarrings, which means scars that are wider than normal, and their skin hyperextensibility. In a lot of people, they will have noticed that. But if these people are younger, so if you're in a paediatric population, they may not have any scarring at all, and they might not have noticed their skin hyperextensibility, or they might not have been flagged that it's unusual. It's interesting in families where families all have a similar condition or they're on the same spectrum. So they may never have flagged these things to doctors as unusual. So any child that's coming in to see me who's talking about getting frequent pain, so for me, any child that's got pain in the same joint that's lasted more than a fortnight, I fully screen as though that child has got a significant pathology of all different types. And from that point, what I then go on to is looking also at hypermobility. And it's amazing how many children do have skin hyperextensibility, but because it's been within the family, that has never been flagged up as anything unusual. And once you get talking to the family about it, mum has it or dad has it, and they're showing, oh, is this weird? And the answer is, well, it's certainly something that needs to be investigated. So just because something isn't reported or isn't reported as unusual doesn't mean it isn't relevant in terms of trying to find out a little bit more about it. Zoe, have you got anything you want to add on what you see in clinic?
No, I think that was really comprehensive. The only other thing I would say is in terms of sort of hypermobility as a spectrum, I think it's really easy for us just to put hypermobility down as, okay, you're a bit bendy, so you're going to have pain. So I think it is really important that we do recognise that we need to be screening people really specifically like that, but it can well be that it's getting pain, but it is because they're on that spectrum. And absolutely, we definitely need to be referring to geneticists to actually get the diagnosis or even confirm a HEDS diagnosis, because they're the people that will be able to look at, do a whole systems check cardiovascular and everything, just to make sure that the patient is safe as well.
And I think sometimes we get into this mindset a little bit that when we see hypermobile EDS, we're seeing quite a sick child, and actually that isn't my experience. When I've seen hypermobile types of EDS, there is still a spectrum even when that has been a diagnosis. So you can have a hypermobile EDS child who comes in and actually hasn't been picked up until they're having a growth spurt and their proprioception is more challenged than normal. And in terms of thinking about that, if you've got that ligamentous laxity, proprioception is challenged anyway. And then if you have a growth spurt and you have the hormonal changes that go with a growth spurt as well, then suddenly you're starting to get pain and dysfunction for the first time. And that's when they often end up at my front door. And it has been very interesting. Every time I feel like I've figured hypermobile EDS out, I see another type of patient who isn't fitting that box. In terms of very briefly just talking a little bit about how we manage these patients, it's very, very difficult to manage them in terms of any kind of prescriptive way. Each person can handle things differently, but if you're getting frequent dislocations, then that is often something that needs managing quite vigorously, and by people that aren't typically osteopaths, but sometimes waiting this along, and osteopaths are involved in that. I certainly have been involved with children that are getting regular dislocations, and I think one of the big strategies there is developing proprioception and muscle tone in a way that is manageable for the patient. So we have to consider that their collagen isn't behaving in a usual fashion, and that their tolerance for exercise and loading is much lower than the average person, and the way that they will build muscle is much slower than the average person. So you've got somebody with poor proprioception with a poor ability to build muscle that would help their proprioception. So changes are slower, tolerance is lower, and that also is relevant for manual therapy as well. So their tolerance for manual therapy is much lower than an average patient type. Now, that isn't at all meaning that there isn't loads that you can do. There is lots. Strapping these patients can be massively important, and exercise prescription where they're using their body and they're starting to build that proprioception can be massively beneficial. And as you do get those changes starting, what you start to find with these patients is very minimal outcomes actually have a maximal effect on that patient's quality of life and perception of their own ability. Because a lot of these people have not had improvements in their musculoskeletal health. So something that might have been minor to a different patient type actually becomes quite a big outcome to these patients. Is there anything else you wanted to add there, Zoe?
No, shall I sort of do a bit of a conclusion?
Yes.
Draw them together a bit. Yeah, so certainly with both Axial SPA and with Ehlers-Danlos as well, they're conditions that we may well see quite commonly in clinic as undiagnosed. So we definitely need to be confident in recognizing them, and even if, you know, obviously these are huge areas, so we're never really going to see a patient and definitively say, yes, I definitely think they have that, but it's just recognizing their signs and symptoms and asking the right questions to be able to screen and then refer on to the specialist to be able to get that diagnosis. Both conditions, they have long days to diagnosis on average in the UK, and they're both conditions that the earlier they're diagnosed, the better the outcome for patients as well. So the sooner we can diagnose them and get them on the right management, then the better, really. And osteopaths can be well placed with that. Obviously, as long as we have the correct training and specialist knowledge in these conditions, we can really help these patients manage the conditions well long term. But it's just making sure that we pick those people up and get them the right diagnosis and the right care as well.
Yeah, and I think the big thing for me as a person who sees a lot of children that I'm involved in that referral with EDS is that if they're not getting referred and managed correctly with all of the weight of the services and the combination of different services that the NHS has to offer, the risk is really high for that child. And the risk isn't only dislocation and injury, the risk is of bony change. So as we grow and our ligaments and our tendons pull on joints and our joints are aligned, that is what creates the bony congruency to give us a stable and a joint that's the shape it should be. If you're constantly having bones that are moving around and they're not doing that, then you get an altered joint shape. Therefore, you get osteoarthritic changes much earlier, and you are also then not exposing that child to the ability to have occupational therapy, physiotherapy, hydrotherapy in some areas if they're still open. So correct referral opens up all the other professions that we can work alongside, and hopefully means that they have a better outcome in terms of their bony development to allow them to be healthier and more robust later down the line. And I think that's a massive point with EDS that doesn't always get considered.
Absolutely, there are some things that you can say, yes, even if it's a delayed diagnosis, you can still work on, like proprioception and muscle strength, but you can't change those structural changes. And with Axial SPA, if someone's progressing along that line and they're getting structural changes to the joints, that's something that we're never going to be able to reverse. So both of them, it is really important to pick people up earlier. And I think as well, both conditions are something that people often present with that widespread pain as well. So both conditions commonly can get misdiagnosed as things like fibromyalgia, chronic fatigue syndrome as well, or even go down the psychosomatic route too. So any patients who are presenting with these general symptoms, yeah, we definitely need to screen and be confident with that.
So I think Katie was going to do a Q&A now.
Yeah, thank you very much, Alex and Zoe. That was hugely informative. As you said, huge subjects in their own right. So I think, you know, having that overview, even from my perspective, you know, it's really interesting. We have had some questions in, so I'm just going to take some of the earlier ones in relation to the AXPAR. I think you did cover this, Zoe, but just for clarity, will patients have all symptoms or just some, as you were detailing?
Yeah, no, very few patients will have all symptoms. Unfortunately, very few patients will be a textbook case as well. So it's quite frequent that a patient may only have 1 or 2 symptoms, and the symptoms can really fluctuate and come and go as well. So both with the inflammatory back pain, but also with the extra-articular manifestations as well. You want to be asking about the historic symptoms, because it might be that you tick more of these boxes with historic symptoms rather than current ones. But the ASAS classification criteria do come in where, depending on if they have sacroiliitis on a scan, they normally will need sort of 2 of the extra-articular manifestations with the inflammatory back pain to be able to then refer on, you know, either for imaging or for that diagnosis as well.
Thanks, thanks, Zoe. We had a couple of questions about the referral letter for AXPAR. That is actually available from the Institute of Osteopathy's website. I have circulated the link to all delegates. If you don't get it, I will add it to the email confirmation that everybody will get after this. So if you have missed it for any reason, we will share that. So I just wanted to make that point. Just moving on. Right, question from Claire. Moving on to HEDS. So one for you, Alex. If a patient has enough of these symptoms to be referred and then given a diagnosis of HEDS, what can then be done to help the patient? What treatment is on offer for patients from rheumatology and/or even osteopaths? What are your thoughts on that?
So I think the first port of call for me, depending on what the patient, how well the patient is looking at proprioception. So how well can that person start to get a sense of where their body is? And then it's also about stabilization. So the question I always ask myself is, what does this person want to be better than it currently is? Does that person need to have a more stable shoulder because they're really passionate about tennis? Or actually, is this person writing a book and needs support for their wrists? So actually, the two would be very different in terms of management. And so I would initially look at proprioception of the body as a whole, just to help that overall quality of life. Slow strengthening, usually starting with an isometric approach, because that seems to be safe for most, and most patients get on well with that without any exacerbation of symptoms. And then bracing is often used in EDS. So bracing, especially in the pediatric population, can be very, very helpful because, again, talking about that bony development, you're supporting the bony development. Any reduction in muscle recruitment during that time will be negated by the stabilization. And also braces are good for proprioception too, because they sort of stimulate where you're holding the person. And then beyond that, they have access, if they get a full diagnosis, they have access to lots of support. So they would be offered NHS physiotherapy, which, again, if we go back to people that are on the more severe end of the spectrum, if they aren't able to work or aren't able to work for a time, then NHS services become massively, massively important because they can't necessarily afford private healthcare. And also, in terms of the paediatric population, they would be offered more support in school, things like tilts for their desks, and they'd be able to get up and walk around. So there are lots of different ways of supporting people, but in terms of osteopathy, then I tend to do less actual hands-on and more getting them confident in using their body, using those muscles to get them a little bit stronger, slowly, carefully, with someone right there like sort of guiding that process. And then if they do have any injuries, then that's when my kind of more classical osteopathy comes in and getting them through a process of injury and then back out the other side, and then we can re-establish their overall process.
One thing I'd add as well in terms of both conditions is that these are long-term conditions. They're not going to be cured. So a really big emphasis is on patient education and empowering patients as well, and giving them then the knowledge to self-manage their conditions too. So often with our longer appointments, particularly in private practice as an osteopath, we really can make the most of that and really help patients. So they're not necessarily going to be seeing practitioners that frequently. Obviously, they know that who to see when they need to, but generally they're going to be self-managing things, and then with the education we can provide.
Thank you. On the exercises, a couple of delegates, Radka and Samantha, are asked if you, maybe this is to send to the delegates after the webinar, if there are any good exercise resources that either of you would signpost to support the exercise prescription that you've just detailed.
So I currently use, and I'm not trying to advertise them, I currently use Rehab My Patient in clinic, and I find it excellent because I really like being able to send out PDFs, really, really, really helpful for patients, and then it links to videos so that I think you get a much better compliance. I sort of hate that word with patients because if they're not complying, they're not doing it for no reason, but you get better compliance because I feel that they feel more confident because they've got a video. But I don't think you necessarily need software. What I used to do before I had Rehab My Patient was just get the patient's phone and video them doing it correctly on their own phone with my voiceover, and that worked really, really well. It just takes a little bit of time. The best tip I can give with exercise prescription is take a good amount of time of your appointment time to do it. Not only because that means that the patient is more confident in doing it, but also if you're investing time, that shows your belief in it, and then that shows the level of importance for this. If you throw them in at the end of the session, then it sort of cheapens it a little bit, and I don't think patients realise always how important it is to keep it going at home. And they see the hands-on therapy took 35 minutes, and then you just did 5 minutes of exercises. Whereas actually, if you really take your time to offer that, then they grasp much more quickly that this is really, really relevant to their recovery. How about you, Zoe?
Thanks.
Yeah, absolutely. I completely agree. The only thing I'd add is that with both conditions, I tend to do some sort of regressions and progressions as well. So patients have a plan of, on a bad day, these are the really gentle exercises you can do. On the better day, these are the things you can progress on to, and give them the knowledge to be able to switch between the two depending on how they're feeling.
Thank you, Alex and Zoe. So we've had a request from Yvonne, said, can we revisit the spade tool? Zoe, do you want to give us just a brief summary? You mentioned the spade tool in your presentation and its function and why it's so useful.
Absolutely. So I've only got the picture of the graph there, but essentially when you go to the spade tool website and you select the tool, you then come up with a list of all the symptoms that I went through. So the inflammatory back pain, the extra-articular manifestations, and the family history you need to ask about as well. It's just got a little tick box, so you tick each symptom on there and press a button, and then it will come up with this graph to give you an idea as to how likely it is this patient may have axial SPA. So it will show, as you can see along the graph there, there's a section where it's additional tests necessary, a section where it's probable diagnosis, and a section with definitive diagnosis. So I'll always send this alongside the referral template letter to the GP. A note though, if someone comes up as a definitive diagnosis of axial SPA, I tend not to send that copy to the patient because I usually explain to a patient, obviously we can't definitively diagnose this, we are referring on for investigations. So if it's something like additional tests necessary or probable diagnosis, I'll send that, but if not, I'll only send it to the GP. But it's really helpful in combination with the letter because it's another validated tool that is well known among all healthcare practitioners. So it's really using something that the GP is going to be familiar with as well.
Thanks very much, Zoe. And again, I think we've asked for the link for the spade tool, so we can provide that, I'm sure, on the confirmation email that you'll all get after the webinar. We've got time for a couple of more questions, which I'd like to pose, if that's okay. So Alex, obviously you mentioned that you are dealing often with the paediatric population. Have you got any particular points of differentiation when dealing with adults who have already had long-standing, obviously, EDS?
Yeah, I think one of the things that's a point to make with adults is if they're aware of their condition, one of the big things is to ask them how well they find what they find helpful. People usually know how well to manage their own condition. Another thing that not everybody has always figured out about their own EDS is that it can actually be fairly syndrome, like it can be quite, you can have peaks and troughs of it for sort of no real reason that people can put their finger on. So if you can sort of discuss that with people and say, oh, do you know what, it isn't necessary that you did your garden. Actually, it could just be that this is having a flare up and we don't really understand why. That can be really helpful in terms of their mental health. But I think my biggest thing with adult patients who aren't well with their EDS is getting them stronger in a way that they are able to, and that is so different for every single person. But as a beginning point, I start with an isometric approach, and to quote a colleague of mine, whatever exercise they like is the best one to do, because it's the one that they're going to do sort of continually. There is really no good you getting them to go to a gym if they hate gyms. And as much as there might be lots of fantastic equipment and they might get really good results if they did go to that gym, if it's never going to happen, then a less perfect exercise would be better. I think if you're thinking much older adults, then we need to be thinking about falls prevention and keeping people as strong and as active as we possibly can. They used to say, so up until about 2010-ish, don't quote me on that, they used to say that people with EDS didn't commonly fracture. Whereas actually we know since about 2016 there's been some literature on that show that fractures are actually more common with people with EDS, and that there is an element of osteoporosis, and they aren't sure yet whether that's due to inactivity and periods of injury, or whether there's actually something more to it than that. So thinking about our older patient type, yeah, keeping them active, keeping them as fit as we can, as strong as we can for falls prevention. And really that there is this balancing act with EDS where you want that muscle to be strong and working really well, but you don't want them doing so much that they're risking a joint subluxation, dislocation, or an injury of a different type that they're more prone to. So there's that weighing up of all the time. If somebody with EDS loved playing rugby, would I think that's a great idea? I'm not sure, it's never come up for me. But if they wanted to play a competitive sport and that was the only thing they really wanted to do, then trying to find a way for them to do that would be massive. And then in terms of hands-on approach, I tend to do about 20% of what I would do with anybody else in a session. Their tissues react quickly and they heal more slowly, so about 20% is usually right.
Thank you very much. So we're just coming up really towards the end. I'm just having a look, see if we've got any other outstanding. So Michelle did ask about manual treatment with EDS, and I think you've probably covered that, Alex, in terms of your percentage. You mentioned 20% of your treatment time is manual. Just to maybe round that question off, are there particular other elements around the manual treatment to be mindful of with EDS?
Well, I would consider deeply whether I was going to HVT anybody with EDS. It doesn't seem, I mean, people with EDS aren't mobile in every single joint, and they commonly, I find, have areas where they have spinal restriction. We could talk about that for hours in terms of the osteopathic thinking behind that. However, again, with their more fragile collagen types, with the potential for subluxations or dislocations, I personally wouldn't choose those techniques, especially as there's other techniques with just as much evidence but no risks attached to them. So I would be very, very hesitant or cautious to ever HVT somebody with EDS. And that goes for AS as well. Not that we're talking about AS right now, but that is an absolute contraindication in Axial and AS as well. So really, I find the minimal approaches to treatment work better. And I think actually sometimes less is more. And when I first started treating people with EDS, I really sometimes felt like I hadn't done an awful lot, and actually they were my best outcomes. And when I thought I had got it right, actually somebody had become worse or aggravated for a time afterwards. So that would be my gauge, is to feel like you haven't really done a lot, and actually that's probably going to give your patient the most benefit.
Zoe, do you want to tip in on that in terms of Axial and manual therapy and maintenance around that for your type of patients?
Yeah, absolutely. So with Axial SPA, both in terms of the non-radiographic and then the radiographic AS, we tend to do smaller amounts of treatment, maybe more frequently, rather than one long session, because quite often patients at the time can really tolerate the treatment well, and then it's afterwards that you get a flare-up of symptoms and you get that kickback of symptoms. So I would tend to do less treatment, but maybe more frequently, so similar to an EDS approach. But also in terms of the manual treatments, we want to be looking at helping someone manage their pain and their function and their mobility. So you're going to look very broadly in terms of, muscular function, joint function, and also just managing pain as well. So generally with treatments, I'd be quite gentle. I'd do a lot of active resisted movements and METs, so you're getting the patient involved as well, because that you can then link into the exercises that you're giving them as well, so they know how things should feel and they know what their sort of safe end range is and things like that. In terms of HVTs in particular, as Alex said, it's completely contraindicated in axial SPA. So not only, obviously, if someone has spinal fusions, you do not want to be manipulating that joint, but also if someone has active inflammation or they've had a period of active inflammation that's then reduced, they can get localized reduced bone density. So these patients, we can't actually tell whether that's happened, but they can be at a much higher risk of insufficiency fractures. So even in someone that's well managed and their inflammation's under control, we do not want to be manipulating them. And there are so many techniques that are much more gentle and can get the same improvement and response, but without that risk. So I think clinically there's no reason why you would choose a HVT really. But we do obviously through ENA we do a lot of webinars and advice on the whole condition and treatment and everything. So there'll be a lot to go into now, but yeah, that's my main thing for starters.
Thank you, Zoe, that's really helpful, and it is a shame because we've sort of run out of time. We have covered most of the questions. There are a couple of others. What we will do is we'll pose the questions to the panelists because we get them all recorded. So if there are any outstanding questions, apologies, but we will get both Zoe and Alex, if they don't mind, to possibly deal with those after the webinar. So I just want to say a big thank you to Alex, a big thank you to Zoe for taking the time out of their busy clinics to do this webinar. Hopefully that we can invite you again for another event later on. And thank you, delegates, for all your questions and interactions. And we'll be closing this down now. Thank you. Bye, everyone.
Thank you.